All right, so my name is Hallie. I'm going to be your NP today. I'm just coming to do a head-to-toe assessment. So I walk in the patient's room, I wash my hands, I would verify the right patient. This is Anna, and your birthday is
04/22/88.
perfect. Then I would be reviewing Anna's vital signs as well as her height, weight, BMI, and her waist circumference with her. That would be done prior to me coming in. So I'm just gonna explain what I'll be doing today. I'll be doing a head-to-toe assessment, obviously address any concerns initially. Do you have any questions for me right now? Okay, sounds good. So just noting the general survey. So I have a pleasant 31-year-old sitting upright, Caucasian female. No acute signs of distress. Just noting general survey. Obviously ABCs right away and address that. Then I'm just going to take a look at her head. I'm noting the size of the head, the shape, circumference, being aware of any abnormal lesions, moles, lacerations, any concerned findings with that. I'd be moving around the patient, looking at different aspects of the head and the scalp and behind, and no concerns there. And then I'll begin by just palpating the scalp and checking the hairline, making sure that there's no bruises or lacerations, no abnormal masses. And looking underneath her hair, behind her ears, really important, as well as on the other side. So just palpating the scalp as well with that. All right, and that looks good. So I'm just going to start with noting the cranial nerves, like cranial nerve 5, so checking for sensation. So I'm just going to take a cotton ball here. If you want to close your eyes for me, I'm just going to swab, tell me where you can feel it. Cheek, okay, cheek, good. Okay, good. And then I'll assess for cranial nerve number 7. So I'm just going to have you smile for me. Good, perfect. And then number 12, I'll have you stick your tongue out for me. Good. So just noting that it's midline, she's following directions, she's alert and oriented, ×4. She knows why she's here today. Do you know what date it is? All right. And then we'll just kind of going through all those aspects as well. And then with that, I would move on to cranial nerve 3, 4, and 6. So checking extraocular movement, checking that pupils are equal, round, and reactive to light and accommodation. So I'll just take a pen light here. Before I do that, I'll just be looking at her eyes, noting symmetry with that, any drainage or lesions around her eyes, and I'll just lightly pull underneath your eyes. I'll have you look up, looking at the conjunctiva, the membranes, her sclera is white, being aware of that as well. So now I'm just going to have you look at my finger here. I'm just going to check for the light response there with the pupillary reaction. Good. So it's brisk, and they're equal, round, and reactive to light. And then I'm just going to have you follow the tip, check for cardinal gazes here. Good. So looking for any nystagmus or anything that would be concerning. And then to the nose. Great. So that looks perfect. Next, I'm going to take my ophthalmoscope and I'm just going to look in her eyes. I'm going to check for the red light reflex, starting on the right eye. I'm just going to have you look at my shoulder here. I'm going to come in at an angle, and then I'll come in quite close to your eye here. So just look up and over. Perfect. There's the red light reflex. And now I'm going to be coming in at an angle. All right, so I'm looking at the optic nerve here. Body, and I'm just looking at the arteries and the veins. I'm looking for any cottonwool bodies. I'm looking for any emboli infarcts. It's crisp. Looks good. All right, then I'll be moving here on the left side. So same thing, I'll have you look here at my shoulder, past my shoulder, and I'll be coming at an angle looking for the red light reflex. Just present there. Now coming in, I'm going to look at the same disc. Now I'm going to be looking for any emboli, cottonwool bodies, any infarcts, all those arteries and veins, and that all looks crisp and clear. All right, after I perform that, I'm going to be moving on to her nose, noting and inspecting symmetry, having her take one nostril at a time and breathe in. So checking patency of the nose, which looks and is appropriate. Then I'll be looking at the nasal septum. I'll have her lean her head back, excuse me. And I'll be looking inside just to knowing any deviation. Any turbinates, any drainage, any polyps, no like bleeding or any concerns. The septum is midline. Thank you for that. I could also check cranial nerve number 1 here. I'll just have you close your eyes. I'm just going to have you tell me what you smell. Alcohol. Perfect. All right. And also I would mention that when I was checking your eyes, I'd be checking cranial nerve number 2, optic nerve with the visual acuity test, and doing Snellen or the Ishihara test for color blindness as well with that. All right, and then I will be checking for her cranial nerve 11, so I'll have you shrug your shoulders. Good, as well. And then I'll be moving on to her ears next. So I'm just gonna take my otoscope. I'm gonna start by just inspecting how the ears look on the patient's face, noting where they are, if they're symmetrical. I'll be looking at the external ear, and then I'll be looking at the internal ear canal. So first I'll be pulling up and back on the pinna just to see if there's any pain or tenderness. Nothing with that. Then I'll be shining my light in the canal of the ear to look at the tympanic membrane. So with an adult, I pull up and back. Good. So no abnormal drainage. Tympanic membrane looks pearly gray. No redness or irritation, swelling, inflammation, bulging of the brain, tympanic membrane. So that looks good. And then I go on this side, I do the same thing. So I just check for any tenderness. While I'm looking at the external ear, noticing if there's any drainage that would be of a concern. And then also on this ear, I would be pulling up as well. Good, and it's pearly gray, not red or showing any signs of bulging or concern for drainage. Yeah, abnormal drainage. So that looks good. When I have the pen light, I'm just going to take a look at her mouth. So I'm going to have her open her mouth for me. Good. I'll be shining the light back there. I'll have you say ah. Good. So that's just checking to make sure the uvula's midline, as well as looking at the tonsils to see if there's any redness or exudate with that. And then I'll be noting, if you want to close your mouth, we can check cranial nerve number 9 with that, which is taste. So I can have her taste something bitter or sweet just to note that. 10 would be the gag reflex, which we won't do right now. But also if there was any concerns with maybe non-conscious patients and retaining consciousness with swallowing. And then I already did the cranial nerve 11, which is the shoulder shrug as well. Something I would note, I would have gloves on. I'd be doing a mucus kind of mouth assessment with noticing if there's any ulcers or any sores within the mouth, checking the gum line, looking at the teeth, noticing if there's any abnormal findings like abscesses or sores that might be present in the mouth. And then obviously asking the patient if there's any pain in there. Also being aware of the mouth on the external component, noting the texture, if there's any fissures or sores on the outside of the mouth as well. Then I'll be moving on to palpation of the face and checking for the sinuses initially. So I'm just going to palpate the frontal sinus. Any tenderness there? No. All right, the maxillary. No. Okay, good. And then I'm just going to be moving through the lymph nodes. So I'm going to start in front of the ears here. Pre, post. Good. And moving down to the tonsillar lymph nodes, and then the submandibular underneath, and then the submantle underneath your chin, and then the anterior clavicle is moving down here, posterior and behind. And then I would be moving down to the supraclavicular, and then the infraclavicular. And then also underneath the armpit, I would be checking for axillary nodes. So looking for anything that's not a pea size or smaller, that's not movable, something that's firm. As well. And then I'd be looking at her thyroid from the front, just noting the symmetry with that. And then I could come from behind and I could palpate the thyroid. And then I would just check for her swallow reflex with that as well. So if you want to swallow, good. So no concerned findings with that as well. No masses present as well. Then I would be moving on. From there, I would be moving on to checking those carotid arteries. So I could auscultate with the bell of each artery. Good, so no buries present, and that's kind of what I've been assessing for that component. And then I would palpate each side one at a time. Normal, it's not bounding, no concerns there. Looking at jugular and venous distension, any concerns there as well. Moving on, I'll move on to the respiratory system. I'd start by looking at the chest. Obviously, they have a gown on. I'd be mindful about privacy with the gown, but being aware I could assess the skin on the chest, looking for any asymmetrical or abnormal shapes, masses, lumps, or any lesions or moles or scars that might be abnormal on the anterior side, and then I'd also check the posterior side as well. And then I would start by palpation, so I would be palpating to see if I could feel like any crepitus or any masses. I would check the front side and then move around and check the posterior side as well. And then on the posterior side, I can auscultate, and since she's a healthy young individual, I can start at the top and move my way down. I take a deep breath. Good. And just making note that the right lung does have 3 lobes. While she's facing this way, I will check her tactile fremitus. I'll have her say 99.
99, 99.
Good. And then I'm just going to check her chest excursion. So I'm just going to see if it's symmetrical when she takes a nice deep breath. Good. So no abnormalities with that. Then I'll take a look at the front side here again. I'm going to listen to her breath sounds on the front side, noting bronchial, vesicular, and vesicular breath sounds, and listening for any adventitious breath sounds as well while I'm going through. Deep breath. Good, so those are clear bilaterally, no concerns there. You could also percuss, and it would be in between each of the ribs as well to percuss if you were concerned about any of the lung sounds and consolidation in the lungs as well. Moving on from the lung assessment, I would be looking at cardiac. We already did the dissection component. And then the palpation piece, I could palpate your arteries, already did the carotids. I would do radial pulse. Good. You could do the femoral pulse, just right in here, and that might be easier to do when she's laying down for her GI assessment. Then I'll do popliteal, good, dorsalis pedis, and posterior tibials. Good, those are equal. You compare them bilaterally with each other as well. And then I would also want to auscultate the lung or the heart sounds. So I would be moving through, I would listen to the valves, the aortic, pulmonic, Erb's point, mitral, tricuspid. Noticing for the S1, S2, any extra clicks, rubs, or murmur. Listening with the diaphragm and the bell of my stethoscope as I do move throughout, comparing and contrasting. All right, and then I flip to the valve. So the places that I'm listening for are the aortic, the pulmonic, the Erb's point, the mitral, tricuspid, and then the mitral. Tricuspid and then the mitral valve. And then also you can palpate the PMI or point of maximum impulse right here. And that concludes my cardiac assessment. I would be moving on then to the GIGU. So I'd ask my patient to lay down. Good. And then I'll just ask them to move their shirt up so I can assess the abdomen. So I'm just looking for any asymmetrical components, looking at the contour of the abdomen, any distension, looking at the skin line here, any abnormal moles or lesions, any protruding abdominal masses that might be there, looking for pulsations, especially above the umbilicus with the artery there, and nothing is present. Next, I'll begin auscultating. So I'm just going to start and move through all 4 quadrants, and then just noting if it's hypoactive, normal active, or active. And if it's absent, I would be listening for 5 minutes. Good, and those are all active in all 4 quadrants. Then I would begin with percussing. So I would just be start at the base and I percuss my way up to her liver, and I would note where the dullness started, where the liver border began, and then I would keep percussing between the ribs and going up to the top. And that would be her liver border, which is usually between 6 to 12 centimeters. I would also do the same on this side, noting for the spleen as well. Then after percussing, I will do some light palpation. Just let me know if it feels tender at all. So I'm just doing some light palpation initially, checking for tenderness throughout. Okay, and then I'll begin some deep palpations. This is checking more for about the organ placement. And you can find the liver right underneath the ribs here. And then moving here, if I was palpating the spleen, I'd be concerned for some splenomegaly on this side as well. Not be able to palpate that. Good. Also, while I'm here, and I could have listened to her umbilical artery, which I will do. You can listen with the bell, the stethoscope with that, and obviously you'd auscultate before palpation. The umbilical artery and then the renal as well. Good. And like I said, this would be a good time to check her femoral pulses on each side as well. All right, and then I could perform the GYGN at this point. Otherwise, I could proceed and then finish it with the GYGN. GYN at the end as well. All right, and I'll have you put your shirt back down and sit back up for me. Perfect. And then moving on, I would check for musculoskeletal system. So I would just be looking at how she's sitting posture-wise. I'd be noting how she moved into the exam table, how she sat down, looking at her gait, if she was ataxic, and noticing mobility-wise with that, how she maneuvered herself, looking at coordination, as well as strength and holding herself up, which she can and is doing. So I can start with her legs. I would just have her initially, I could have her check for coordination. So I could have her lift one leg up and then lift the other leg up. Good. Then I can check for strength tests. So I'll have her kick out and I'm pulling. Good. And then I'm going to push and you kick out. Great. Same thing with your legs, one at a time. Good. Great. And then I'll have check the feet. So I'll have her scoot back just a little bit and then we push like pedals, pull back. Good. So she's got equal strength bilaterally. I'm going to check her arms as well. I'll have you abduct them away from you. Perfect. And bring them back down. So just looking at range of motion, you can bring your one arm up and the other arm up. Good. And I can check strength with that. So I can have her put her arms out in front of her. I'm going to have you push down my hands and then pull up. Good. Squeeze my hands. Good. So equal strength bilaterally there as well. I can have her do the empty can test and then just checking there too to see strength wise where she's at. Good. And then essentially with that, I would have her stand up and then I could have her close her eyes and check the Romberg's test. So essentially, I'm just looking to see if she's going to drift or fall when I lightly tap and push you and just stand still, maintaining safety with that. And so she's able to. Great. And you can put your arms out in front of you. I'm going to have you close your eyes. I'm going to have you touch your pointer finger to your nose and back out. Good. Great, so she's maintaining coordination and balance with that as well, which is great. And then like I said, I saw her ambulate to the exam table. While she's standing, I'll have her bend over, kind of turn. And if you want to touch your toes, I'm going to just look for scoliosis, especially on younger patients. So you're just going to want to look at the spine, make sure it's midline. You're going to be looking at the scapula and just looking for any deviation that might signify a bend or curvature. I could use a scoliometer as well. And just note if that was abnormal or crossed over at all. With that, perfect. And then I'll have you sit back down. And then for my neuro exam, I kind of already went through the cranial nerves. With that component, I will check sensation though. I do have a dull and a sharp point. So this is the dull, and then this is the sharp. All right, so just tell me which one you feel. Dull, sharp, dull, sharp, dull. Good. And then down here, sharp, dull, sharp, sharp. Okay. Sharp, sharp, dull. Okay. So if I had any concerns, I'd be checking distally and working proximally. Obviously, I'd be moving up towards her torso as well, checking the sensation in her extremities. With that, I can also do another test where I'll have her close her eyes for me. I'm gonna have you hold out your hand. I'm gonna place an object in her hand. I'm gonna have her tell me what it is. Clean, perfect. Excellent. And then I'm gonna have you keep your eyes closed and your hands still out. And I'm gonna draw a letter in her hand. She's just gonna tell me what it is. S. Perfect. Thank you. So there's a couple things. I can also have you keep your eyes closed. I'm going to touch a part. You tell me where I'm touching on your body. Right there. Left leg. Right leg. Left arm. Okay, perfect. So that addresses those components, and then I would check for her deep tendon reflexes. So I'm just going to check for her brachial initially. So have her relax. I'm just looking at the muscle twitching up on top. Good. Good. And then I'm going to have her relax her hand here. And I'm just going to check her her tricep. Good. And then her tricep on this side. Just relax. Good. Good. And then I'm just going to check her patellar. I'll have her scoot back just a bit. Perfect. So right here. On this side. Good. And then I will check for her ankle response. Good. Good. All right, so those are addressing the deep tendon. I could also check for Babinski, so just taking it and running it along her feet. I should not expect her large toe to fan out. That would be concerning if you're at positive Babinski in an adult. That's not good. All right, so after that, I would be noting her skin and integumentary system. So I did a lot of that throughout when I'm doing the inspection component, but just being mindful about any abnormal skin lesions. Note the texture, the color of her skin. I'd be looking at the bony prominences, checking for pressure ulcers or pressure sores. Obviously moving her gown for those things and being private with the patient's gown throughout that as well. The other thing I would be checking would be the nails. So I'd be looking at cap refill with those. And then I'd also be looking at going down, looking at her legs and see what those look like for skin turgor, as well as edema. I could do that while I'm checking the skin or even during the cardiac assessment, and just noting the warmth of her skin as well. It's cool or warm. And that concludes my head to toe assessment. Do you have any further questions for me at all? All right, thank you for your time.